measles. And again, just want to a little bit emphasize that though we give childhood vaccinations, but there are a lot of concerns, and many of the infectious diseases are coming back, and they're talking about the lifelong immunity, the change of strains, and what do we need to do because of the public health problem that we may have for some of the diseases like measles and rubella. But you can see from here the extent of vaccinations that are happening and the progression of vaccine and the impact of viruses, and then again the diseases that we normally see in real time. Anyway, the next virus is mumps virus. It's also an acute. Most of the time, the presentation of this virus is painful swelling of the salivary gland and parotids. This is in front of the ear, right? So that's the typical presentation, parotitis. And again, it's a envelope virus. And then again, remember that it says contagion period precedes symptoms. So you may be infective before you know it, or maybe you're passing it on to other people. Asymptomatic shedding is important. Host range is limited to humans, so your pets are free. And again, when I say only one serotype, you know the answer is that immunity is lifelong. As of now, but I already discussed with you some of the problems that we are seeing. It is recurring, it's coming back. Mechanism of disease, which is pathogenesis, is that it has got tropism for epithelial cells of respiratory tract. And then again, it goes to the blood. And remember, I said that wherever the blood takes it to, but when it goes to some of the vital organs like central nervous system, that becomes serious. This particular virus has a liking for parotid gland. The other important thing is that it has a liking for testes as well. So gonads. And then again, we'll discuss that in detail today. Presentation is inflammation of parotid glands. Cell-mediated immunity is required. Antibody is not sufficient because of virus ability to spread cell to cell. And we remember we talked about the viruses causing typical pathophysiology. Now, if you look at your book, again, one will acquire that from a respiratory tract. Remember those inoculating loops that we show you in the microbiology lab? This means that you pick up a portion of microorganism and plate it up. So that's inoculum. The dose required. So it replicates locally. And then you get viremia, systemic infection, and three important structures that it wants to attach to. Parotid as a clinical presentation. Pancreas, they think, can be associated with juvenile diabetes. So that's another important aspect of mumps virus. And then, as I just told you, of all the other attachment that it has, central nervous system, the most important are gonads, testes, and ovaries. Okay. Now, the time course of mumps virus infection, again, you will see on the bottom line, there are days. So you basically have 14 days, about like 14, a little bit more, where you may have acquired the virus. You don't see any symptoms, you don't see any disease pattern like over here, and you are still passing it on. But orchitis, parotitis, that's very obvious, painful. And then again, at this time, you can recover the virus from mouth or urine. So that's where you want to acquire virus. And then you want an antibody response. Antibody response can be picked up later. So if you go to a clinician with a swollen parotid gland, he's going to run a test for antibody if you're mounted very specific antibody response. The dangerous stuff is meningoencephalitis. and that may come 1 month after the infection that you get. You can see from here, but these are earlier on. So the first clinical symptoms is orchitis. Okay, so that's where the gonads are going to get affected. Now, as I said earlier, the problem is that you may have been harboring this virus, or the child may be harboring this virus, going to school for 14 days, passing it on to other people. And then finally, when they present with this parotid swelling, so what you would see over here is that this particular virus has not only liking for one secretory gland, which is salivary gland, it has a liking for other glands as well, which are producing secretions. Like some of them are semen, for example, ovaries, mastitis, the breast tissue, pancreatitis, and thyroiditis. So what you will see is this particular virus is a liking for cells which produce secretions in different forms, whether it be salivary secretions, whether it be other secretions in terms of juices like pancreatic juice. But the typical presentation as is called mumps. So many times when we investigate an infertile couple after marriage, so we ask them that, were you ever infected with mumps? Because if you were infected with mumps in childhood, this is one of the very common cause of sterility for both males and females. So this virus kills your ability to reproduce. So that's the significance of mumps virus. When it goes and affects central nervous system, again, I said that's a serious problem. It causes meningoencephalitis. And then again, you can see from here, 50% of the patients, we can recover the virus. And then again, there are statistics that sometimes it presents as meningitis, infection of the meninges covering, and some other cases, encephalitis is important. So this is a typical presentation of a child. You can see a swollen, painful parotid gland. You can see, and this is a typical parotitis. And most of the viruses, it says almost always bilateral, because virus kind of jump from one place to another, and they always are accompanied with fever. And you cannot miss that. Once you see a baby with this picture, right, the chances are mumps virus. So how do you diagnose that? Well, we can recover the virus from saliva, urine, pharynx, secretion from different parts of the body, and grow them into culture. And remember, I said that you have to have a cell line. In this case, you can see we used to grow them on monkey kidney cells. And if you look at the morphology, remember I said one cell dies, it removes the cell membrane and jumps to another cell. So it keeps on killing the cell to such an extent that you, under the microscope, will see a multinucleated giant cell. So multinucleated giant cell is a typical for like a appearance for the viruses, because of the ability of the viruses to kill the cells and join all these cells together. A clinical diagnosis is that if you have a mumps-specific IgM antibody, that is the normal test that we normally do, or you can run the other tests that we normally do for ELISA and genetic tests and other tests to detect antigen antibody. But the most specific is mumps-specific IgM antibody. So mumps-specific antibody, this is the common test they do clinically to prove infection with virus. How do you control, prevent? Again, vaccination remains the most important thing. And you can see that we have live attenuated vaccine since 1967, and we put it as a part of MMR. And any specific antiviral agents are not available to take care of this particular problem. Okay? The next in line is parainfluenza. It's not an influenza. Keep that in mind, right? And it's a virus. It's not Haemophilus influenzae, which is a bacteria. So these things you have to keep in mind, especially as part of your questions, that sometime as we can put that up as a distractor. It presents as a respiratory virus, and all the way from a very mild symptoms to a very serious respiratory tract. And there are different types. And if you were to look at young infants coming with respiratory problems, respiratory syncytial virus remains number one cause, and then parainfluenza comes number two. In terms of very severe lower respiratory tract, and you pretty much know upper respiratory tract and lower respiratory tract. Upper respiratory tract is like cough and pharynx and larynx and tracheobronchitis, and for the lower respiratory tract, pneumonia and all these kind of things that are there in these infants. Now, croup is also a very specific kind of a cough or infection of the lung that comes with parainfluenza, and it has a seasonal variant. So you will see that happening in more autumn, whereas especially for 1 and 2. So if you next time look at the weather report, and you will see in medicine section, they will talk of allergen, they will talk of viruses, and CDC also maintains a record of what is happening in this particular time, which viruses are there. And this is for pediatricians and physicians to pretty much know that what's happening. So very common question asked that parainfluenza virus 3 is present throughout the year, whereas viruses 1 and 2 have a seasonal incidence to appear only in autumn. And this is how the virus looks like. And then, as I said, 1, 2, 3, but there are other types as well, serotypes, and the infection is mostly respiratory tract, depending upon which particular organ of the body is affected. The important thing is, which you can see from here, parainfluenza virus do not cause viremia. If you were asked which of the following viruses that I've talked so far cause viremia, I told you measles cause viremia, I told you mumps cause viremia, but parainfluenza does not. Okay? So the chances is more of a respiratory virus alone. It's not going to go and cause problem. Okay? And then again, as I just told you, depends upon the problem that we have. Croup is a clinical word that we use for laryngotracheobronchitis. So if you're asked, what does the croup do? So it's going to cause inflammation of larynx, inflammation of trachea, inflammation of bronchi. We call laryngotracheobronchitis, this croup. That's a typical kind of cough that these people have. If you get infected with these viruses, you may have an immunity, but this short-lived immunity. It doesn't really last well. If you look at, for example, another structure in this case, again, would signify that the bilipid layer virus, the outer membrane, then you have these, I told you the other day, other than lipid bilayer, you have heme agglutinated neuraminidase, right, which serves as an attachment protein. And some of them are other proteins. For example, you can see some of the proteins line the internal, we call matrix protein. So all these proteins are there that may eventually become targets of our antiviral therapy. Because by the end of the day, all these things have to be made by your cells or our cells to assemble that. Okay, so that's something that you need to keep in mind as a whole for these viruses. For example, if in this case, if it happens to be heme agglutinin neuraminidase, this is in parainfluenza only, right? But in respiratory virus, this basically acts as an attachment protein. So some of these viruses being grouped together as a larger family may have some similarity and dissimilarities. Okay, why is it important? Right now, I'm not suggesting that you're going to use the same kind of drug therapy. But if you remember the very first day when I taught you the steps, early phase, late phase, and what's happening in terms of the antiviral therapy. So we have to stop those virus attachment, penetration, unfolding, macromolecule synthesis, assembly, and then budding out, and so on and so forth. These are the typical steps that are basically targeted by our antiviral drugs. And again, many times when I say viruses are small and big, size does matter. You referred to the original picture I showed you the very first day, RNA virus and DNA viruses. For example, if I was to ask you, what is the significance of virus being large in terms of the assembly of the viral components? What would be the major criteria if I tell you if it's a large, what's going to happen, which part of the cell the assembly will take place within the cell, had it been a large virus? Okay, cytoplasm. Remember I said that the larger would not be able to penetrate the nucleus because they have nuclear pores. They usually are smaller viruses that they basically go into the nucleus and then expand. Host range is limited to humans. And again, this has become very common feature. Contagion period precedes symptoms. So you are contagious to other before you actually show the symptoms. Okay, so many of the viruses, including this group, are such. Reinfection can occur. And as I said earlier, presentations is usually depending upon which group of population is there. Older children and adults generally experience milder infection, and it's especially in younger children we may get, I told you, croup, laryngotracheobronchitis. But in elderly people, they, because of the waning immunity, they may present as pneumonia. The elderly people may have a pneumonia because of the way we deal with that. Okay, and then again, if you want to Google that and find out what croup is, so basically when you have all those larynx, trachea, bronchi inflamed, and you cough, they call it like a barking kind of a cough. That is barking cough, and the moment the babies cough that way, you can pick up that that kind of a noisy thing coming from upper respiratory tract. And the difference between, for example, epiglottitis, which is inflammation of the lid that closes, trachea, okay, and let the food go into a food tract, because the inflammation is in that area. So you can see that epiglottitis is caused by bacteria. It is not caused by that. Okay, so that's usually a very common question asked. How would you differentiate parainfluenza infection from Haemophilus influenzae bacterial infection? And the answer is differentiating is epiglottitis, which is present in bacterial infections. Lab tests you can do, as I said earlier, monkey kidney cells, more or less academic if you want to go for the serotype, and then you look at pathology. And if you really want to look at tests that are available, these are called rapid tests. Most of them are like rapid RT-PCR type tests. So they are fast and they can be done immediately. And the reason is that we want to identify parainfluenza viruses between 1, 2, and 3. And also we want to make sure, remember in the I told you they are released in urine and they are released in secretion. So that's important for us for the lab diagnosis. How do you treat it? If patients have croup, we want to give them nebulized cold or hot steam and want to monitor the upper respiratory tract. Very rarely we have to intubate. You put the person on respirator. if necessary. No specific antiviral agents are available other than the one I already told you in general. When you give them vaccination with killed vaccine is ineffective. Because remember, we want to give you a live vaccine because that will kind of provoke your immune system to go a better response than the kill response. But unfortunately, as of now, we are unable to give any vaccine per se. So no live attenuated vaccine is available as of now. And the reason being, if you give live vaccination, it may cause and precipitate the symptom itself. So that's always a challenge for us until we find out which part of the virus is the one that is referring immunity on you. And the respiratory syncytial virus, that the one that I showed you that Abbott made the drug against, F protein antibodies against, humanized antibodies against F protein of that attachment, which is a fusion protein. And again, this is localized in the respiratory tract. Also keep in mind that this also does not cause viremia. So I would want you to differentiate between two viruses causing viremia and some of the viruses do not cause viremia. And again, they may not go for systemic spread. Pneumonia results and cytopathology. And I've been saying it over and over again. One of the cytopathology of viral infection, I told you, multi-nucleated giant cells. The other pathophysiology, I said, inclusion body. The third pathophysiology is syncytia. Syncytia is that when the cells are there, the virus jumps from one cell to another, so it kind of puts them together, joins them together. And syncytium is like a network. Okay, so that's another important aspect for virus. And then again, the problem in young infant is that when they have bronchitis and their bronchioles get inflamed, they also become asthmatic as well, because asthma basically is narrowing of those respiratory bronchioles. Okay, maternal antibody does not protect from infection, and if you have a natural infection, again, it does not prevent reinfection. The other problem, especially addressed in this case, is that we say, hey, give the vaccination. And many a time, I think if I'm correct, that as a part of immigration, people have to present childhood vaccination certificate. But many a times, the vaccines are not properly dosed, and so on and so forth. There could be many reasons for the failure of that vaccination. But anyway, this is important. Now, I don't want to spend much time on pathogenesis, but the thing that you need to know is that regardless of the nature of the causative agent of upper or lower respiratory tract infection, when there is an inflammation, there is a narrowing of bronchi, depending upon how much is the damage, you will see different kind of damages. So, for example, all the way from cell death to cell necrosis, all the way from asthma to very severe pneumonia, especially in the younger infant. That's why the Abbott is selling that monoclonal antibody to prevent that F protein, blocking that F protein so it doesn't go and attach to the respiratory cells of those babies. And one of the things that happens in younger patient is that in response to a necrosis of bronchi, they form plugs. So this is like plugs of mucous fibrin and necrotic material. And then many times they give you expectorants. So you want to cough out so you clear your respiratory tract, or you give steam inhalation. The idea is to open up those bronchial. But sometimes the babies, they cannot do so. It forms like a plug. So if it keeps on forming plugs, that's again very important as pathophysiology of this particular respiratory syncytial virus. And again, you can see from the name, it suggests respiratory syncytial virus. So it's going to cause a lot of necrosis and a lot of damage. And then the other problem is that you can see there is no natural immunity. And vaccination, as we just give you an example for that, is to some extent working and decreasing in that. So this is what is the mucus plug. So you can see from here, this is a normal bronchiole. It gets inflamed. The diameter is decreased. And in response to the cell death, in response to the secretion, there will be a mucus plug. So you can extract it out, right? But if it's in very small little bronchioles, it may be tough for you to do that. And that happens especially if it happens in the lower lobes of the lungs and it's not properly ventilated. So you may see local damage for these particular infants. Again, you can see from here obstruction of the airways to give you the problem in terms of causing it bronchial asthma. So people sometimes say, hey, this child has asthma, so you need to investigate the cause of asthma. Some of the causes of the asthma, especially for the babies, is basically a lot of viruses. So if you can see a constriction of bronchi, then you can also look at the whole pathophysiology that the viruses are involved. It could be superadded bacterial infection, and all of them can add together to plug and cause problem. The other thing that you can see from these fusion proteins, they are just for demonstration purposes, few of them, but there could be tons of them. They go and strictly attach to those cells, and we want to stop that to help, okay? And as far as global annual rates are concerned, 64 million, very high. Mortality, 160,000 babies dying, again, is a very high. And then again, many a times the problems are at least 1/3 of the patient, and you can see from here, is lower respiratory tract. And a small percentage of these babies are to be hospitalized. And in terms of burden on CDC, on hospital system, you can see that respiratory syncytial virus will be responsible for about 95,000 children being hospitalized every year. So that's where many times they want to public health policy matter, and public health issues have to be addressed in terms of speeding up the therapy in these cases. I don't want to go in detail for clinical features, but I think you must have realized this thing over and over again, that depending upon which organ is involved, how severe the organ is, what's the age of the patient, if there is any other superadded bacterial infection, that will determine as to what is happening to those particular patients. And all the way from a very mild illness to a very severe pneumonia. And I just kind of copy and pasted from your book. But the thing that you have to remember for respiratory syncytial virus, other than the typical acute inflammatory changes that happen in pneumonia, regardless of whatever the cause is, the most important thing is this remains fatal in premature infants. So premature infants, it remains fatal. People who have underlying lung disease, they already have cystic fibrosis, for example, they have any other congenital disease, or they're immunocompromised. On top of that, if you get hit with this virus, then this is a killer. So these are kind of the things that you need to know in terms of the severity of the disease. The other thing is, remember I said a common cold is self-limited, no need to bother. Make sure that you don't give this advice to the mothers for the young infants. It may not be common cold. It may be respiratory syncytial virus. So anything in babies, anything in younger children has to be taken seriously. An older adult, again, things are different. So that's a message for respiratory syncytial virus. As far as treatment is concerned, other than the symptomatic treatment, that you want to help the asthma, give oxygen, you want to open the bronchioles. One of the things that we normally give is ribavirin, which is a gynosine analog. I'm going to come to that in a while. And then again, passive immunization can be done as a anti-RSV immunoglobulin. What is passive immunization? Mother give it to? No. Yeah. That's adoptive. A passive immunization is you are not activist that you want the body to make antibodies. Passive is you give antibodies. You don't wait. Right? So it's a passive. So what you, an answer is already there. I'll say anti-RSV immunoglobulin is available. So you're not waiting for the baby or body to produce those final cells. You are giving it to. So passive immunization most of the time is an antibody specifically to help. You don't want, what's the reason for that? Why do you want to go for passive immunization? No, you're giving them antibody. Active is when they make their own antibody. Why? Huh? Louder? Avoid a disease. Of course. That's what we're helping. But what's a good reason for passive immunization? Well, the reason is because active immunization is done in a healthy person. If passive immunization is given to a person who's already sick. And if you remember immunology, the difference was active immunization is going to take time. Passive immunization is you just give them the thing needed at the very moment. You cannot wait. Right? For example, you can give a tetanus shot before you are involved in roadside accident, but when you get a roadside accident, you don't give an active immunization. No, you want to give passive immunization because it's too late. Does that make sense? And then there are formal measures that we normally keep in mind. No vaccine is available for RSV. And then again, there were a lot of tries, but it goes back and forth. The whole idea is that we have to be careful because once we give a virus, especially a live, that itself can provoke a lot of problems in the system. Okay? So I'll stop here, overlap to the next one. Rensport can come.